Hello, sorry to interrupt.
Yes.
And will it be okay to start the next session?
Okay.
Okay, thank you. And so next session will be about the clinical application of the Theranostics, and I will introduce this session. And I'm Min-Seok Soo from Seoul National University. Uh, I'm a medical doctor. So I will introduce about, okay. And before starting, I would like to ask everyone a favor. I have a write down a link in the chat box. You can check in the chatting. There is a link, and it is about a survey of this workshop. So I would like to ask, please participate in the survey before, after or belong in the middle of the lectures. And I think all your suggestions will help us to actually more upgrade the contents of this workshop in the future workshops. So I would like to ask everyone to participate in the survey. So thank you, and I would like to start the second session of diagnostics in nuclear medicine. So as I have already introduced, there is a emerging interest in the market for the radioactive drugs. And in this year, last year, the endocyte, Novartis actually again dealed $2.1 billion for endocyte, which had produced PSMA agent. And as previously mentioned, Novartis has had a deal with AAA for the lutetium-177 glutathione. So it is very promising that these kind of big pharmaceutical companies are having interest for the radioactive drugs. Actually, this is a table of late development with radioactive drugs which are approved or which are in clinical trials. So before the LUTATHERA, there has been a radioactive drugs such as Javelin or Bexar. And these drugs has shown their effectiveness in quite a lot of studies and clinical trials. So they got approved. However, these drugs have not in a regular use in the clinical situation. It is, there are some reasons such as these are not actually in the clinical guidelines, or these drugs are not provided by the big pharmaceutical companies. There is some disadvantage competing with the big pharmaceutical companies. However, recently, many other recent drugs that are Xofigo, LUTATHERA, or lutetium PSMAs are actually provided by the big pharmaceutical companies. So these may have an advantage for the competition in the market, and it will, I think this will actually, again, grow our field. So I will start with the neuroendocrine tumors. So neuroendocrine tumor was first commented on tumors of small intestines, and it was coined as a term like carcinoid. And the neuroendocrine tumor begins in the hormone-producing cells of body's neuroendocrine system. And it is frequently unpredictable and has an unusual biological behavior. And actually, it frequently presents late after delayed diagnosis, which actually has a difficulty for the treatment and management. There are types of neuroendocrine tumors can be divided in the location of their primary lesions, and the small intestines takes the most of it. And we can classify the neuroendocrine tumors by their mitotic rate and Ki-76 index, so, to grade 1, 2, and 3. And these different grades had different prognosis. And as mentioned earlier, these neuroendocrine tumors have some difficulty for diagnosis and also treatment and management because these neuroendocrine tumors has very heterogeneous group of tumors, and it shows wide variety of clinical presentation. And also, in late presentation, over 60% of neuroendocrine tumor are advanced at the time of diagnosis. And the median survival for patients with advanced neuroendocrine tumor is 33 months, which is very low. Sorry for the okay. Yes, and this neuroendocrine tumor has a different terminology and classifications. I am sorry, I would if it is possible, if you can mute, it will be helpful to go on for the lecture. I think there are some sounds coming in. So the neuroendocrine tumor actually is increasing, and it is there is a compared to the incidence of all malignant neoplasm, the incidence of neuroendocrine, the increasing rate is more higher for the neuroendocrine tumors. So there is a emerging interest for the treatment of neuroendocrine tumor. And before that, we need to diagnose this tumor. So there are tumor biomarkers that can be used. And there are also new potential biomarkers such as microRNAs or circulating tumor cells. And we can use imaging studies, such anatomical imaging such as CT and MRI, and also functional imaging, which is somatostatin analog ultrasound scan or gallium dotato PET-CT. And final, for the gold standard, we use a biohistological diagnosis. And the as earlier, the functional imaging, we used a somatostatin receptor on neuroendocrine tumor. And somatostatin is a somatotropin release inhibiting factor and are produced in the hypothalamus. And it has multiple biological functions. And it is highly expressed on neuroendocrine tumors. And this somatostatin receptor has 5 subtypes. And actually, in the neuroendocrine tumors, the subtype 1 and 2 are the major subtypes. So, and there are several therapeutic options for the neuroendocrine tumors, such as firstly, we can do the surgery. And actually, there are some options for chemotherapy using Porphox or platinum-based chemotherapy. And secondly, there are options for the targeted therapy using everolimus or the vessel targeting sunitinib or bevacizumab. And there are drugs that are used for the somatostatin, using somatostatin analogs such as octreotide or lanreotide. And finally, there are newly established drug, which is the PRRT, using lutetium or yttrium DOTA somatostatin analogs. So as you can see in the neuroendocrine tumor consensus guidelines, we use this, there are many therapeutic options, such as a somatostatin analog or PRRT and also everolimus. So for now, there is no one gold standard treatment right now for the second-line therapy of this neuroendocrine tumors. Firstly, the somatostatin analog for the treatment in the neuroendocrine tumor, it has an effect in the tumor cell survival. So it has an effect for it lowers the apoptosis, and it lowers the growth and proliferation of these tumor cells. And also it has an effect for lowering the signaling and secretion. So it can not only treat the patient, but it has an effect for managing the symptoms of the patient too. And there are other drugs such as a targeted agent, such as a mTOR inhibitor, everolimus, and it has an effect for the cell metabolism or protein synthesis and cell proliferation, tumor cell itself, but also this mTOR inhibitor has an effect in the neovascularization. And also these other sunitinib or bevacizumab, which targets this vessel, has a therapeutic effect. So there are many kind of drugs that now are used for the treatment of neuroendocrine tumors, and it has been proved its efficacy from a lot of clinical trials. So these are some recent and ongoing phase 3 clinical trials in advanced neuroendocrine tumors. So right now, there are studies that have been already completed, and these are some clinical trial landscape in neuroendocrine tumors. So it uses different drugs and different targets, but these all have shown their effectiveness for the treatment of the neuroendocrine tumor. However, there are some limitations of the randomized or placebo-controlled trial using this targeted therapy. Firstly, it is impossible to compare the outcome of one study to another. Only it has been compared using comparison with not to other therapies, other drugs. And overall survival is difficult to assess since results are confounded by high crossover rate. And data from placebo indicate this may be feasible in patients with low risk profiles. And with targeted drugs, they neither achieve cure nor high objective remission rate, but frequently stable disease state. So there has been a need for a new, more effective drugs. So recently, the PRRT peptide receptor radionuclide therapy has been introduced as a molecular therapy for the neuroendocrine tumor. And these PRRT are currently being investigated as a treatment option for prostate and pancreatic tumors. And it has a cell targeting, it uses a cell targeting protein octreotide as a ligand, and it puts a therapeutic radiopharmaceutical such as yttrium-19 or lutetium-177. And from the NETTER-1 clinical trial, it has shown a effectiveness for both the progression-free survival and also the overall survival. So by these results, this LUTATHERA has been approved by the FDA. But so it has also been introduced to the clinical guideline. But what may be the next, and what are some ongoing clinical trials for this lutetium dotatate drugs? So there are new randomized controlled trials and prospective trials for broadening the indication of this drug, PRRT. And there is also an ongoing study for the comparison with other targeted therapy agents. And there are some studies for the validation of new therapeutic strategies, such as combination with other drugs or selective intra-arterial injection, or using other alpha particle for the therapy, and also somatostatin, not analog, but antagonist for the therapy. So firstly, I would like to introduce NETTER-2 clinical trial for grade 2 and grade 3 neuroendocrine tumor. And actually, inclusion criteria is quite similar to the previous NETTER-1 trial. However, the difference is that it includes a patient with higher KI67 index, which means these patients have more poor prognosis. And interestingly, as you can see in the exclusion criteria, the exclusion criteria is that if this patient have any previous therapy, including interferon, everolimus, or chemotherapy, they cannot be included in the study. So actual purpose of this NETTER-2 trial is to set up a evidence of LUTATHERA as a first-line therapy. So after the surgery, whether it can be used as a first-line therapy may be proved by this NETTER-2 clinical trial. And there are also ongoing trial of everolimus comparing with the lutetium dotatate. So these complete trials are done in 300 patients in more than 11 countries. So this will show up what may be more effective for the second-line therapy of the neuroendocrine tumor patients. And for new strategies, there are combination of therapy, combination with PRRT with PARP inhibitor, or some strategy for it, as neuroendocrine tumor frequently show a liver metastases. Intra-arterial injection of these PRRT drug may have more effect with lower safety issues, safety risks. So this strategy are used. And also there are some ongoing trials for alpha particle or somatostatin antagonist use. So this is a study of using the alpha particle for the therapy of neuroendocrine tumors. So there will be many broadening of application of LUTATHERA and many other strategies that we might use in the near future. And nextly, I would like to discuss about the prostate cancer. And actually, prostate cancer in Korea also is increasing for men's tumors. And 10 or 20% of men have advanced prostate cancer at the time of diagnosis. And more than 40% eventually progress to metastatic castration-resistant prostate cancer, which is mCRPC. And mCRPC is considered a less lethal phenotype of prostate cancer and is defined as disease progression despite the pharmaceutical or surgical castrations. And the standard treatment for these mCRPC is systemic taxane-based chemotherapy or anti-androgen pharmaceuticals and some antibody treatments. But recently, there has been a new emerging target for these mCRPC, which is the prostate-specific membrane antigen PSMA. And these PSMA is mainly expressed in prostate cancer and in tumor-associated neovasculatures. And it is actually highly expressed at all stages of the disease. And it is upregulated in androgen insensitive or metastatic diseases. And it is also expressed on the cell surface as an integral membrane protein and not secreted or released into the circulation. And when they take up by this receptor, they are internalized after antibody binding. So using this PSMA, there has been an attempt to label this PSMA with a therapeutic radioisotope, which is lutetium. And this lutetium PSMA 617 has reported a phase 2 study and has showed a efficacy improving, and they used a primary endpoint as a 50% of PSA response. And they also use a radiographic progression or quality of life as a secondary endpoint. And as you can see in this graph, there has been many patients who had a response using this therapy. But there has reported some, although not significant, there has been some side effects using this drug. And the most frequent side effect was dry mouth. But there were not grade 3 or grade 4. Because this PSMA is highly expressed in the glandular, in like salivary gland has a high uptake for the PSMA. So when treating with lutetium PSMA, there has been a frequent report of dry mouth. And now I would like to introduce some ongoing clinical trials for these lutetium-based therapeutic agents. So firstly is the VISION trial, which is the phase 3 clinical trial for the lutetium PSMA 617. And it compares with the best supportive care. So it includes a patient who have undergone every options of treatment, such as a chemotherapy or androgen castration and also antibody therapy. So patients who have no option left are included in this trials to see whether it has effects on the over endpoint as progression-free survival and overall survival. And the results of this trial may accelerate the approval of this drug in the FDA or in the European markets. And there is also, like lutetium dotatate, also a combination of drugs with a comparison of this PSMA drug comparing with the taxane-based chemotherapeutic agent. And also there are some studies using PARP combination with PARP inhibitors. And also there is a study named PRINCE, which is an ongoing study with combination with immunotherapy and the lutetium PSMA for the prostate cancer patients. However, this lutetium-based PSMA has an efficacy of near 45% of patients, and it has a biochemical response of dropping of PSA level. However, near 40% of patients actually do not respond at all. And because the prostate cancer, or advanced prostate cancers frequently have disseminated bone metastasis, it may have a diffuse red marrow infiltration and red marrow toxicities. So actually using this lutetium PSMA drug, there has been a frequent report of leukopenia or anemia or thrombocytopenia after the treatment. And also the grade 3 and 4, the most frequent grade 3 and 4 toxicity was reported in relation to the blood suppression of the marrow functions. So new drug, there has been an attempt to using alpha particle for this purpose using actinium-225. And since this alpha particles has a shorter energy range, it may have a less toxicity for bone marrows. And also, it has some studies have shown that this, as you can see, this patient had undergone lutetium PSMA therapy. However, the PSA did not have no response to this therapy. However, after the actinium therapy, this patient had a significant response. So there are some studies to see whether this actinium-based drugs are actually more effective compared to the lutetium-based drugs. But there are, considering the PRRT, such as neuroendocrine tumor, and for the prostate cancer, there are still some concerns. So firstly, it's about the response evaluation. Actually, we can use a gallium DOTATOC PET-CT or gallium-based PSMA for the diagnosis and to pinpoint the patient who will respond to the patient. However, using this imaging agent to evaluate the response is another problem, because there are some cases after the therapy when there is a progression, and if the tumor cell gets into the de-differentiation, the actual targeting receptor can be less presented in the cells. So after the therapy, the actual, although the response is progression, the uptake of using this imaging, targeted imaging agent can show a less uptake. So these response evaluation is still in some concerns. So there are some consensus meetings to evaluate, to make a consensus for the response evaluation. And nextly, there are also a problem for the personalized dosimetry. For now, we use a very fixed dose for every patient. However, there are studies that are suggesting that personalized adjustment of personalized dosimetry and adjusting the dose may be effective for the patient. So there are some clinical trials for personalized PRRT of neuroendocrine tumor using dosimetry. And now I would like to introduce some new future target for the nuclear diagnostic approaches. So we have discussed about this lutetium glutatate for the neuroendocrine tumor and lutetium PSMA for prostate cancer. And what I want to introduce is the fibroblast activation protein, which is called FAPI. So cancer-associated fibroblast is actually tumor mass consists of cancer cells, but also vascular structures, inflammatory cells, and fibroblasts. And these make up the tumor stroma, and they can account for 90% of the tumor mass. And cancer cells induce a fibroblast activation by this TGF-beta. And these cancer-associated fibroblasts have some function for metastasis, angiogenesis, and cancer metabolism. So it has supporting function for cancer growth and invasion, and it can contribute to the remodeling and promote the invasiveness and angiogenesis. And it is involved in the immunological interaction between the tumor and the host. So fibroblast activation protein is a transmembrane cell surface proteinase that degrades proteins of the extracellular matrix. And these fibroblast activation proteins are upregulated in cancer. And it is highly expressed on the cell surface, and it is not highly expressed in the normal tissues, or it is very lowly expressed. So this FAB can be a novel tumor target, and it can also be used for diverse tumors. And actually, this FAB is highly expressed by cancer-associated fibroblasts. So, and these FAB positive cancer-associated fibroblasts are found in more than 90% of these epithelial cancers. So there has been an attempt using this FAB as a new target for tumor, and the German Heidelberg group has recently developed a quinolone-based FAB inhibitor, which is called FAPI, and it used with a DOTA chelator. It has made a gallium after attaching gallium, it can be used as an imaging agent for the tumor. So this has been used, and it has shown promising results, showing a tracer uptake in 28 different kinds of tumors. And compared to, and as you can see for the normal distribution, it only shows some uptake in the excretory pathways, such as a kidney and bladder, and not other organs has a high uptake. So the background to tumor ratio is quite high, which is a promising imaging agent. And so the advantage of these FAB-targeted imaging is that it can detect a small lesion effectively, And detecting tumor lesions with low or heterogeneous glucose metabolism can also be imaged using this new FAPI-based imaging agent. And also early imaging at 10 minutes after injection is possible, and it doesn't require fasting. So it is more easily, the preparation is easier compared to the FDG. And there, using this FAPI new novel agents, there has been also attempt to label this with a therapeutic agent such as yttrium or lutetium. And this group have shown that after labeling with yttrium, it can have a therapeutic effect, and it showed no toxicity in their study. So there are some ongoing clinical trials for this new agent. Mostly are about the imaging labeled with gallium-68. And these trials will show the effectiveness of this FAPI-based imaging. But still, there are needs and there are possibilities to label this with therapeutic agent and to use it as a therapy. So there is a many chance for this new novel drug. And what I want to lastly show is that from the first in-human study of lutetium dotatate, it took 20 years to apply this therapy in Korea as a first clinical trial in Korea. And now in 2020, we now have started the first trial for lutetium dotatate. And it took almost 20 years for this one. However, for the PSMA, it took, compared to the first in-human study of this PSMA agent, the first clinical trial in Korea took 5 years. So now we will go for this lutetium PSMA in Korea in 2020. And I believe if although the development was not done in our country, but we can be a fast follower and we can introduce this drug more earlier. And these new diagnostic agents can be our future products. So I think everyone can have some, I think it will be good to have some interest in these new coming theranostic agents. So thank you and if you have any questions or comments, please freely ask anything.
In terms of cost effectiveness, is it the best alternative to what we're currently using?
Sorry,
hello, doctor. I'm Nabil, Dr. Nabil. I have a question.
Yes.
My question is, in terms of cost effectivity, is lutetium-177 better to the alternative that we're using in the diagnostic procedure?
So the cost effectiveness of lutetium actually,
I think maybe there is no cost effectiveness study about lutetium-177 yet.
And actually, normally using lutetium as a diagnostic agent, because the efficiency of the gamma from the lutetium is actually not, I think, not effective for a diagnostic agent. So, but there as commented from Professor Yoon-Sang Lee, there is no comparison of such a cost effectiveness of using lutetium as a diagnostic agent. But there are also some attempts to label these agents with the technetium, which can be, which may be more available for in the clinical use.
Right, exactly. See, this is what I was asking, is if we compare the prices of lutetium to technetium, which is providing the better alternative, and do the diagnostic criteria match up to those requirements?
So I think we need to, there should be trials, but I think using the technetium might be, may have advantage. And so I think the study should actually need it, but labeling with technetium may alter the characteristics of these drugs. So I think validation is necessary for future process.
Thank you. Thank you very much.
Dr. So, would you comment on the unsolved problem, like the differences in effectiveness of therapeutic effectiveness of actinium and also lutetium, which is alpha and beta? And again, the second question, which was raised during Indonesian meeting, the PAPI. In case of PAPI, do you expect, or does anybody expect that lutetium, which is a beta emitter, having the longer range, is going to be better than the alpha emitter? So because we are targeting not a tumor, but the tumor surrounding cells, the cells in the tumor microenvironment. So comment for both in terms of dosimetry, or you can promise that the kind of difficult question is going to be dealt with in the next meeting or so.
So the difference between the alpha and the beta particle is, as Professor Lee told, is the length, actually the length, but there is also difference in the energy. In terms of energy, the alpha particle has a higher energy. So in the clinical applications, there are some different, some consensus that a tumor with a higher burden may have more effective using lutetium-based drugs, since they have a longer range of the energy transmission. However, in like small tumors or disseminated lesions, there are some consensus that these alpha particle may serve better results for the treatment. However, the actual difference between these both agents should be, there should be a study to validate whether what might be a better option for the treatment. And for the PAPI, as was actually questioned in last week from Indonesian group, considering the PAPI, actually this PAPI is not a tumor cell direct targeting, but it's a so when targeting this PAPI, actually alpha particle may have some limit transmitting the energy to the tumor cells and to have a therapeutic effect. So maybe lutetium might be the best option for this kind of PAPI therapy. And lastly, for the consideration of the dosimetry, actually lutetium dosimetry can be done by imaging agent, imaging the lutetium scan. However, the alpha particles have some limit because it cannot be actually imaged. Actually, it cannot be, like actinium-225 cannot be imaged. So there are many considerations how to do the dosimetry regarding alpha particle. Like there are some attempts using surrogate markers for the alpha particles. But this more detailed, I think, may be discussed in the winter meeting with Professor Jae-sung Lee. So I would like to also welcome you to also participate in the winter workshop. So is there any, yeah.
Sir, okay, I have a question. I am Dr. Mohammad Anwar Azim.
Yep.
Actually, with the link of my previous colleague, Dr. Nabil Fahmi Ali,
Yep.
I actually not comment, I want to do some comments. So actually, lutetium is a therapeutic. There's two things, diagnostic and therapeutic. So lutetium is used for the therapeutic. So far, I understand from the question of Nabil Fahmi Ali, he emphasized on the affordable agent for the diagnostic purpose actually. So in that case, maybe PSMA we can use depending on the availability compared to, and also efficacy compared to technetium. Gallium is the I think more accurate agent actually, because we have we can produce gallium from a generator. And also now recently we can also use it, produce it from cyclotron also. So maybe for us who want to begin this type of things for the diagnostic purpose actually, so we can actually consider gallium rather than technetium as a better agent. So what do you think?
Right, thank you. I know, I'm aware that yttrium and lutetium are the therapeutic modalities in general. So this is actually what I was trying to extract out of whatever the doctor had shared with us. It has diagnostic potential, but yes, you're absolutely right, Azim Bhai. It is the better alternative would be gallium in terms of diagnostics. Thank you.
So what is your comments, Professor, about this? I need some comments, feedback from you about this.
So actually, if it is available, using the gallium-based imaging might be the best option, is actually my opinion for the imaging of diagnosis of these tumors.
My other comment, please. I actually, from another lecture from the QC lectures.
Yes.
So we actually are planning to have a with the assistance from IAEA and HPG gamma counter in our cyclotron center. So again, for the production of only FDG actually, for the FDG QC, is it mandatory to have a HPG gamma counter, or it should be better to have one for a cyclotron center? What's your?
I think Professor Yoon-sang Lee can.
So
okay.
you said that you will get the new gamma
yes.
counter.
I have proposed to IAEA for funding us because there is some fund in our TC project. So with the HPG gamma counter. So so is it okay for because we are now only concentrate on the fluorinating production. For our future endeavor, is it okay to have a HPG gamma counter in our center?
I think if you available, I think you should get a different gamma HPLC system with the gamma counting. I think there is a flow cell. They possess the flow cell with the gamma counting system, so you can make a radio HPLC chromatogram. Is that right? Yeah.
Yes.
So
yes.
in case of F18 production, you don't have to do the HPLC. So if you get the HPLC with the gamma counting flow cell, then I think you'd better use that for therapeutic radiopharmaceuticals. That's better. Okay.
Okay.
If you have
Thank
only
you.
one, then I think you should dedicate that HPLC system for therapeutic radiopharmaceutical. That's better. Okay.
Okay. Thank you.
Thank you for the comments and questions. So if there is no more, we would like to have some break for, I think, 8 minutes, and then we will begin after 8 minutes. Thank you.
Thank you very much.
Thank you, everyone.